Welcome everybody, Dana Bruzzo here. Today we're going to cover the topics of bleeding control and shock. It's probably not shocking to you that these two topics come together, but hopefully by the end of the lecture you'll understand that shock doesn't just mean bleeding. There are other etiologies of shock. Our goal today is going to be to understand some of these different types of shock. So first off, let's just kind of give ourselves a general outline. First topic is going to be to talk about blood loss, to talk about bleeding, to understand what bleeding actually is, what the importance of preventing bleeding and stopping bleeding really is for us. Secondary to that, we want to start to understand shock as well. How do we identify it? What are the different types of shock? We want to investigate this principle of compensated versus decompensated shock, understand where patients are at in the general progress of their illness when they are experiencing shock as patients. We want to find what the underlying causes of shock are. Again, as I already mentioned, there's multiple types, and we'll investigate those individually. Finally, the goal when you leave this lecture is to have a really good understanding and appreciation for what your tools are, what the limitations to your tools are when it comes to treating shock in our patients. So let's go ahead and take a step a little bit closer to the bloodstream and investigate what the different components of blood really are. So we know that blood's important, it's essential for life to continue functioning, and so what is it composed of? So obviously we need the volume of blood. And a huge portion of that pure volume, the fluid that we transport all these different components in, is what we call plasma. And so this plasma, as we can see, is about 55% of our total blood volume. We can fit that into the category of the fluid components of our blood. And around 92% of plasma is just water. So you've always probably heard that your body is composed of about 60% water. That's why we need to keep drinking. Well, we might not call it exactly 60% in the case of our blood, but when we consider intracellular and extracellular fluid as well, well, that H2O is obviously a huge component of our body, and it is a huge component of our blood. The remaining portion of our plasma are other elements, sodium, potassium, other smaller ionic compounds that are dissolved in the bloodstream. So if we move from our fluid component of our blood, which really helps create the right viscosity of our blood and it helps dissolve different products inside of the bloodstream, we can move on to the actual formed elements. So these are more cellular structures that have specific functions. And so the biggest portion of that we see is our red blood cells. So red blood cells, or erythrocytes would be the fancy term for that, comprise about 90% of our formed elements inside of our bloodstream. So a huge component. They're a big working force, and we'll talk about a little more why we care so much about red blood cells here in a second. Just briefly to mention it, the remaining 10% of our formed elements inside of our bloodstream are really our white blood cells and other components that really contribute to the clotting cascade. So those include what we call thrombocytes and platelets. So you can think of the other 10% really a part of that inflammation, immune response when we're either fighting off infection or trying to fix or heal an injury. So take one step back to our red blood cells. I'm sure you've seen a nice picture of the flattened disc shape of a red blood cell. We actually don't have one in the slide to show today. But the main reason why we care so much about these red blood cells is that's the location where we carry our oxygen to the tissues. So we know very well by now that oxygen is required for the sustainment of life, and the actual carrier from the lungs to the rest of our tissue of that oxygen molecule is this nice molecule inside of a red blood cell called hemoglobin. And this hemoglobin molecule allows for the attachment of these oxygen molecules. It carries it down to the tissues where that oxygen is needed to be used, and it'll offload that oxygen in that area of the tissues to be utilized in metabolism and cellular respiration. And so that's the big reason why we care so much about the red blood cells, is they allow us to transport that oxygen Without the oxygen there, obviously the red blood cells can't grab onto anything, and so that's why we're so worried about the respiratory system when we go into respiratory failure. But if we lose the carrier, if we lose all the red blood cells, all of a sudden now we have a different way to get hypoxic, and that's because we actually don't have any carriers to move that oxygen around the blood. So as far as just general quantities, we have for an average adult male a volume of about 6 liters of blood. Obviously, the smaller we get, the more female we get, the less blood we have inside the body. So let's go ahead and do just a quick reminder of the circulatory system, how this all functions, what different components we have, just to remember. So again, I've already mentioned we have oxygen-rich blood that we've enriched with oxygen by passing by the air that's inside of the lungs. So inside those little alveolar sacs, we can pick up some oxygen. That's covered more specifically in the respiratory anatomy and physiology lecture. But once we pick up that oxygen onto the red blood cells, well, now we need to distribute it to the rest of the system. So we're actually going to return that oxygenated blood from the lungs to the heart, and then the ventricles of the heart, specifically the left ventricle, is going to move that blood from our heart to the rest of our body. So it's moving that oxygenated blood to the tissues. Once the blood gets to the tissues, it's going to offload that oxygen. It's going to unload carbon dioxide that's being created by cellular metabolism, and it's going to transport that CO2 and other waste products back to the lungs, and hopefully get rid of some of those waste products in the lungs and in other tissues. And so that's kind of our circular path. Again, we're moving oxygen-rich blood from the lungs to the tissues. We're returning oxygen-poor blood, CO2-rich, from the tissues back to the lungs with the hopes of unloading more oxygen and getting rid of some of that CO2. So the big highways for our blood to move are generally divided into the arteries and the veins. The arteries are carrying high pressure blood to the tissues. The veins are returning low pressure and low oxygen blood back to the heart, back to the lungs to become reoxygenated. So we see that the arteries are closest to the ventricles. The ventricles have the highest pressure. They're moving the blood the furthest away from the heart, and they want to do it quickly. So they have the highest pressure, and so when it comes to bleeding, we'll find out that arteries are the ones that we really worry about because they have the ability to move blood very quickly to our tissues. Well, if all of a sudden we interrupt that highway and we're exposing it to the exterior environment, we have a really quick way to get rid of a lot of blood very easily through that high pressure system. And so essentially when we're palpating a pulse on an artery, we're feeling that pressure wave. We're feeling the pressure inside of that vascular system hit up against those walls, and we're feeling the actual contractions of the ventricles in that system. So we can imagine all that pressure. If the integrity of the wall, the artery is disrupted, well, it's going to move blood very quickly to the external environment. So just very simply breaking down the components of our circulatory system, this will come really into play when we think about the etiologies of shock. We have pumps, pipes, fluid, and signals. So more specifically, the pump refers to our heart, the actual pumping mechanism. The pipes refer to our veins, our arteries, the way in which we move the blood through. The fluid itself is the blood. It's the plasma, the red blood cells, the white blood cells, everything that's inside of our blood that we just learned about. And the signals, maybe the least obvious of the four here, the signals are referring to the combination of the nervous system and the cardiovascular system. So we'll find that in all of the smaller arteries that we have inside of our body, we have a surrounding layer of contractive tissue that can either restrict or expand, depending on what our nervous system decides. And so in order to maintain blood pressure, in order to keep the right amount of blood in the right places, our body and our nervous system is constantly contracting and expanding these smaller areas of our artery system. And so in doing so, effectively redirecting blood and maintaining hopefully that appropriate 120/80 kind of classic normal blood pressure. And so one of the ways all of this system can get out of whack is if that constriction and relaxation gets out of whack. So we'll find out some of the ways we can get to that sort of situation a little bit later. And finally, it's good to just note it in your mind right now that cardiopulmonary resuscitation, CPR, is effectively stimulating the circulatory function. And the one that we're specifically stimulating is the pump. So if the pump starts to have dysfunction, then we can kind of simulate that contraction and simulate that pressure and move some blood through the essential organs of our body. So tolerating blood loss, bleeding again is one form. We can have a problem with the fluid, and that fluid, specifically the problem we're talking about now, is we're having a problem of the volume of the fluid. So if we have blood loss, we can kind of break it down into these classifications of blood loss. I don't expect you to memorize this chart specifically, but it gives a nice outline of what we should expect from our patients when they experience blood loss. So at around 750 milliliters, almost 1 liter of blood loss, we're really in a pretty normal state. We can tolerate that amount of blood loss pretty well. We can see that's around 15% of our total blood loss. Likely we'll see a heart rate that's normal, it's less than 100. Well, blood pressure is probably going to be normal. Respiratory rate, 14 to 20, maybe it's slightly elevated. We're trying to compensate for that little bit of blood loss, that little bit of hypoxia. Our urine output, don't worry about that. That's going to still be pretty normal. We're not retaining all the fluid that we can. And the CNS system symptoms, another way to put that is our level of responsiveness is going to be pretty much normal. So in this class 1, up to about 750 milliliters of blood loss in the average adult, we see that we don't have any changes happening. Basically, our body is compensating for this loss of blood. We might be in this situation of compensated shock. We'll talk about that more specifically in a minute. But largely, our physiologic function is still pretty normal. As we progress to about 15 to 30% of our blood rate, of our blood loss, we start to see some changes in vital signs. We start to see some changes in physiologic state. Up to around 30%, our body is still doing a pretty good job of maintaining our physiologic function. We're still doing a pretty good job of oxygenating all the important tissues. But as we move into 3 and 4, which is really about 30 to 40% blood loss, that's when we really start to die of shock. That's when our body really can't keep up with the amount of blood that we've lost, because we've lost so much of that oxygen carrying capacity. We've lost so many red blood cells, we've lost so much of that hemoglobin to the environment that we can't get the oxygen to the important tissues. So we start to see changes in our level of consciousness. We see confused state happen all the way to lethargic. It can enter easily into a coma, and we get all of these vital signs that really get out of control. So we see a very high heart rate, very high level of tachycardia, increased respiratory rate to try to compensate for the loss of oxygen carrying capacity, and as I already mentioned, we see changes in our level of responsiveness. So we've now kind of talked about when we're worried about blood loss, at what volumes. One note of caution, it's pretty much impossible to evaluate blood loss. There's certain science behind how can you teach people to estimate volume of blood lost, but in reality, it's pretty hard as a practitioner, even if it's something that you do every day. So don't get too consumed with amounts of blood loss that you're expecting. What we really want to focus on by the end of this lecture is how do we recognize a blood loss or some other sort of state of shock that's life-threatening versus one that's self-correcting. And so when we talk about the blood loss, the first thing we want to learn is how do we control blood loss. I'm sure everybody here knows, just from common sense and living in a modern society, that we have some pretty easy tools, and the first of which is always direct pressure. So you probably learned this as a grade school child. If you fall down and skin your knee or get a nice nasty cut on a rock that was laying on the ground, well, we need to apply some direct pressure. In our environment, that ideally happens with a nice clean piece of gauze and a pair of gloved hands. As we can readily expect in the wilderness, we don't always have ideal situations. So it might be just an extra shirt, some sort of piece of clothing that's the most clean on top of the wound, applying direct pressure. We want to put significant pressure on these wounds. It might hurt for our patient or for ourselves, but the important thing is to try to get control of this bleeding very rapidly before the blood loss really catches up with us. And so, in effect, what we're trying to do is stop blood flow to that area in order for the clotting agents in our bloodstream to find whatever perforation or damage has occurred in those blood vessels or capillaries and clot it all up. So we have kind of this internal clotting going that we're allowing to occur because we don't have such high pressure. If there's a real high pressure, we're not applying direct pressure to counteract the pressure of the blood flow, then these clots try to form and they just get broken off. They try to form and they just get broken off. And that's why it continues to bleed. So direct pressure is our number one savior in terms of preventing blood loss. One thing we can do to help is elevate the wound. Essentially all we're doing is we're using gravity to help us. We're not having gravity hurt us by increasing the pressure and increase the amount of little clots that are blown off. We're doing quite the opposite. The next step we can try to take is what's called a pressure dressing. This is something you'll practice in your practical sessions, but it's a nice way if you need to do something else with your hands. If you're a lone rescuer and you don't have the capacity to just keep your hand on a wound, or your patient is unconscious, not able to put direct pressure on their wound themselves, it's a nice way to maintain that pressure while you address other issues. And so you can see a nice picture here of a rolled up piece of gauze that is further bound to that injury with additional wraps, creating what we call a pressure dressing. It's effectively simulating your hand pushing down on that wound. So what if it keeps bleeding? We've tried direct pressure, it keeps bleeding. We've tried direct pressure, it keeps bleeding. We notice that there's a profuse amount of blood loss, and when I say it keeps bleeding, well, this is a really active bleed. It's making you nervous just to see it. It's not drizzling, it's not kind of weeping blood into that area, but there's an active flow of blood coming from that wound. If we can't stop the bleeding, we have to try something else. So really in our environment, it would be very rare that we have to actually use what we call a tourniquet. Likely we're going to have a situation where we have maybe one patient. We have the ability to maintain direct pressure, hopefully with our hand. The situations where we might jump to a tourniquet a little bit early are things like battlefield environments, care under fire, or simply an MCI where we don't have the hands to be able to control some pressure. And MCI stands for mass casualty event, basically the situation where we have more patients than we do have responders. But anyway, backtracking to a situation where we might use one, normally this is going to be an arterial bleed. I mentioned arteries are the high pressure system in our body where these clots that are trying to form are easily blown off just by the pressure wave that's created inside of that artery. So in the case that we, again, cannot control the bleeding, to recognize our arterial bleeding is pretty obvious. You will notice the bleeding occurs in a pulsatile fashion. It might legitimately shoot across the room. And this sort of bleeding can be very hard to control with direct pressure, but again, that's where we're going to start. The idea with a tourniquet is that we actually occlude all blood flow to the limb. So the highest pressure system is that artery. Our goal is to completely occlude any blood flow going through that artery. What that does is it prevents any blood flow entering that distal limb. So as you probably know just from general understanding of tourniquets, maybe through the media or just living in society, the worry that we have eventually with a tourniquet is that we prevent perfusion of that limb. So all of the cells that are inside of your arm that are that's further away from your heart than that tourniquet are starved of oxygen, they're starved of nutrients, and they're accumulating toxins that we normally try to get rid of. In this situation, we've essentially decided that this person's life is at risk if we don't risk their limb. But all of that said, let's kind of take a moment to really think about tourniquets, to understand some facts about tourniquets. So I already mentioned this, it really should be a last-ditch resort if you cannot control bleeding with direct pressure or a combination of direct pressure and pressure bandaging. In general, we kind of have this time frame that we consider when we utilize a tourniquet in the appropriate fashion. Less than 2 hours, if the tourniquet is on for less than 2 hours, the limb survival with no neurovascular damage is pretty likely. So that might be surprising to you. You might think that that time frame is even shorter, but in fact, when we look at some literature, and a lot of this literature comes out of the military, we see that if those tourniquets are addressed and the bleeding addressed in a very controlled environment, a definitive setting, which would really be a hospital, then the limb survival less than 2 hours is pretty high. As we move from 2 to 4 hours, now we start to enter into our world of complications. It's very likely for these patients that they'll have some varying degree of neurovascular problems down the line. It's hard to say how significant that is. Not every limb injury is the same, but we just want to understand that that's kind of the middle gray zone. As soon as we extend back past 4 hours into the 4 to 6 to 8 hour range, now we have a real risk of limb amputation. So obviously the neurovascular damage is almost guaranteed at this amount of time that a tourniquet's been in place, but the bigger worry becomes this patient might actually experience an amputation later on because that limb does not become salvageable at all. So one of the ways we can hopefully prevent and kind of extend this time frame is what we call releasing the tourniquet. And so the big thing to focus on when we release tourniquets is we do it slowly, and we only do it if we think the bleeding is actually controlled. We don't do it because we're so worried about saving this patient's limb that we're going to risk additional blood loss by loosening a tourniquet. We really do it just if we notice that the bleeding seems to be controlled. So if you've attempted to loosen a tourniquet after about the first 10 to 15 minutes of it being on, and immediately as you loosen it, you notice a big rush of blood flow, turn the thing back on. We don't want to just sit there and wait for additional blood loss to occur. Maybe the better situation would be that you've waited about 10 to 15 minutes for that tourniquet to work. You slowly loosen the tourniquet up to allow some reperfusion, and you notice that the blood flow out of that wound is pretty minimal. In that situation, you might have saved that patient their limb or at least some neurovascular damage. If at some point down the line that clot breaks off, it starts to bleed again, resetting that tourniquet and waiting another 10 to 15 minutes before we reassess is really what we want. In the situation that there's really profuse bleeding, you can tell the only thing that's stopping that bleeding from occurring is the tourniquet that's in place. It's best to just hedge your bets for their life and not their limb, leave the tourniquet on place, and focus on immediate evacuation. We'll have the time to practice tourniquets and their actual, the practical application of them in the field sessions. It's really hard to describe it in front of you on camera. So, moving past blood loss, let's start talking about shock. Obviously, you have already connected blood loss to shock. That blood loss is one mechanism that we can get to shock, but let's step back and look at an overall broad definition of shock. So we want to use the terms inadequate tissue perfusion to define shock. And it's important to take that step back because we can understand that we can have decreased perfusion or decreased delivery of oxygen to the tissues by various ways, right? They go back to our circulatory system in general. And that goes back to our pumps, our pipes, our fluid, and our signals. And those are really some abnormalities that can cause inadequate tissue perfusion. It's not just blood loss. Try to disconnect those two ideas and welcome in a few other mechanisms. Really, shock results when the tissues do not receive adequate blood supply. That's both the delivery of nutrients and oxygen and the transportation and the excretion of toxins. So, we already mentioned bleeding as a form of a contributing factor to shock, but let's kind of put that into a broader classification of decreased blood volume. So this is really talking about the fluid. There's a few other mechanisms we can get to. One is vomiting and diarrhea. So that's another good way to get rid of a lot of fluid very fast, especially in the third world where we do not have effective means of rehydrating patients when they can't feed themselves or they can't take oral rehydration. One of the leading causes of death is essentially shock in patients that are so volume depleted from vomiting and diarrhea they can't sustain their tissues. Another one would be the pump. We see heart attack, severe heart disease, and vessel changes. These are our pipes. They can either be problems in the pipes themselves, maybe they're disrupted. It can also be problems in the actual signals to those pipes. So now let's talk about those fancy terms, compensated and decompensated shock, and why we care about them. So compensated shock is exactly what it sounds like. It's our body compensating for the shock that it's undergoing. So it's noticing that we're having either low blood volume, or it's noticing that we're having some sort of heart failure. It's noticing that there's an improper signal to some of our vasculature, and it's going to compensate. Well, what does it do to do that? It really relies on our heart. It relies on our heart to pump harder, it pumps faster, and the vessels themselves are also going to redirect blood flow to the important parts of our body. So we're going to redirect blood flow from the exterior, from the skin, it's the first places that the blood is going to leave, from some of the larger skeletal muscle groups, back to our core, back to our essential organs, especially our head and our heart. The results that we see from a vital standpoint are going to be increased heart rate, so tachycardia. We see an increased respiratory rate as well. We can guess that that's in order to increase the amount of oxygen that we're throwing onto those hemoglobin molecules. Normal is a hallmark of compensated shock. We don't expect people that are in compensated shock to show any kind of altered mentation. And finally, we have this kind of subjective term, but really important, of reasonable blood pressure. So maybe we see that their blood pressure is starting to decline. It's a little less than maybe it was when we first saw them, but in general, it's much well above our threshold for sustaining life. So above 100 systolic, above 60 diastolic, somewhere in there, we will consider that a reasonable blood pressure, and they're really in that state of compensated shock. It's very possible that they'll have a completely normal blood pressure in this state of compensated shock. But what we really look for our hallmarks of compensated shock is some reason to believe their pump, their pipes, their fluid, or their signals are out of whack, and we see an increased heart rate, increased respiratory rate. Everything else seems to be pretty normal. As we move over to the right side of this screen and investigate decompensated shock, it's basically our body saying, okay, I know that the tissues are not receiving what they need, but I just can't keep up anymore. The heart itself, the mechanisms by which we have to compensate for shock are becoming underperfused themselves. And so they're oxygen deprived, they're going to start to fail, and all of a sudden we don't see the compensatory mechanisms happen. So we see that the heart can't pump any harder, we see that the heart can't pump any faster, and that the blood vessels really fail to correctly direct that blood volume back to the important parts. And so way late in our decompensated shock, we can see a decreased heart rate. A good thing to note right now is that likely before the heart rate decreases, it's going to be extremely, extremely elevated. And that thing might be in the 150s, it might be in the 160s, and this patient is laying down flat, completely not exerting themselves. Another hallmark is going to be that we see decreased mentation, and finally that we see a poor blood pressure. So maybe we start to lose a radial pulse, or it becomes very, very weak and thready. If we do go ahead and check a blood pressure, we start to note it's getting below 90 systolic, below 80 systolic, below 70 systolic, and that's not enough to sustain all the essential tissues. And so eventually, if we don't correct that shock, that patient will die. So signs and symptoms already mentioned these, but more specifically, and an additional skin component, which is really important in the identification of shock. With a patient who is in compensated shock, a lot of the times we will see them slightly pale with a slightly delayed capillary refill. But if they're truly compensated, they should be reasonably normal in presentation. As they move, and again this is kind of a spectrum, it's not black and white stages, but as they move from compensated shock into decompensated shock, we really see a profound decreased capillary refill, and that's because all of that tissue, or all of that blood flow is redirected towards the essential organs, and very cool and very pale skin. And I mean very, very pale. These people look like the dead bodies that you see on any kind of TV show, and they can look quite terrifying just on presentation. Other notes: heart rate might be extremely elevated, blood pressure is tanking, it's really going down. This isn't exactly a lecture on pediatric patients, but just to note a small difference in shock between pediatrics and adults. A lot of the time, in a pediatric patient, the only reliable indicator of shock that we have is an increased heart rate. Very commonly, a pediatric patient who is in shock will maintain a pretty good blood pressure and a very elevated heart rate for quite a long time, until their body just can't handle it anymore. Their heart rate will drop, and their blood pressure will drop very fast as well. In an adult, a lot of time we see the trend that the heart rate continues to increase as the blood pressure drops, and we really have some time when we see their blood pressure dropping to act and to kind of counteract that process. With a pediatric patient, as soon as their blood pressure starts to drop, we're within seconds of that really becoming a horrible event. So shock treatments, we haven't gotten into the basic individual kind of reasons that we get into shock other than bleeding, but the shock treatments really apply to pretty much everything. So it doesn't quite matter if you know exactly what type of shock it is or why this patient's in shock. What's important is that you recognize the generalized signs and symptoms of shock and you treat it accordingly. So as always, start with the ABCs: airway, breathing, circulation. Extremely important in this situation to increase the oxygen content in the blood. One way to do that is if the patient's not breathing, we're going to supply ventilations for them. If they are able to breathe on their own, or even if we are supplying ventilations for them, we want to increase that concentration of oxygen. We all know that the environment in our atmosphere is composed of about 21% oxygen. By turning on supplemental O2 and delivering that to our patient, we can increase that 21% to around 70–80% oxygen, which is really going to help that patient move blood to the tissues that has oxygen on it. Obviously, first thing, stop active bleeding. That's kind of the C component of our ABCs. We also want to keep this patient supine, and by supine we mean laying down on their back. We have nice access to their airway, and we're ensuring that the blood is not fighting gravity. We're not trying to move blood from the dependent limbs back to the core. We want to keep this patient warm because we find that with any kind of trauma, with any kind of blood loss, hypothermia causes more problems than it helps. Splinting major fractures can help reduce the amount of blood loss. Reassuring and calming our patients can help reduce the pressure in their cardiovascular system. Initiating rapid transport and requesting a higher level of care, it gives us another avenue to treat their shock if there's not an obvious one we can address. And really, for prolonged care in a patient that has compensated shock, but you don't have access to IVs or anything like that, if they're able to maintain their airway, if they're not feeling nauseous, they're not feeling like they want to vomit, and you know that surgery is not right around the corner for this patient, oral fluids can help replace some of that blood loss if blood loss is the problem.